So what we are doing first is to cut longitudinally at the mandibular level, as you can see here, just signaling with the knife, making a kind of triangle until the mantonian area, and then we will cut the skin until the entrance of the thorax, and we will open completely until the ischiopubian symphysis. So the procedure is as easy as that. So I make one triangular cut in there, so the cuts are very easy to be seen, and then just with the knife I can separate the skin in a very gentle manner until reaching the entrance of the thoracic cavity. In order to proceed for the opening of the thoracic cavity, sometimes we are using what we call the costotome in order to cut the costal wall, so the ribs. However, instead of cutting the ribs by the bone, we will try to cut them by the cartilaginous area. So the point is try to cut, as we can see here, at the cartilaginous area. And first of all, I have been opening just the thoracic cavity, but this is a procedure that can be performed very fast, and then open as well the abdominal cavity. At this stage, we have a vision already of the thoracic and abdominal cavity. Imagine for a while that we are in front of a process like polyserositis, fibrinous polyserositis, and we are potentially interested in taking samples for microbiological analysis. This would be an excellent moment to take the sample. And what we recommend is to take liquids in case that there are liquids in the different cavities, but if there are no liquids and there's just fibrin, then a SWAB can work very well. So the possibility of taking a SWAB, of course, as you can see, we have not touched at all the thoracic or abdominal cavity. Of course, with a different one, we will do exactly the same for the thoracic cavity, but then the sample is there and it's ready to be submitted to microbiological department. Of course, we will have to note and annotate all the data from the animal. Okay, at this stage, it's very important to see if all the organs are in the right position and in the right situation. As you can see, the abdominal cavity, you always see the liver. Sometimes the spleen is not observable because it's still covered by some of the intestinal loops. We have the urinary bladder, here we have the cecum, and mainly a small intestine. Okay, we have the abdominal cavity here, and we need to remove all the intestinal loops. There are several ways of doing so, but the one that we recommend is sometimes, especially with the students, to make some knots, especially at the rectum, at the duodenum, in order to ensure that there's no content fade away. So we will do such a procedure here. Also, we will remove, first of all, the spleen. The spleen is very easily to see in here. So it's, as you can see, this organ, which is quite hidden here, but it's not that small. So as you can see, we have the spleen in that part, and what we will do is to separate using the omentum, which is attached to the stomach, in order to remove the spleen in its globality. So we have the spleen. We will leave the spleen as well for further study. Right now, we are in the process of removing the intestine. I know that the knots are very difficult to be performed under field conditions, but we recommend to do it especially if you want to take some samples afterwards. So, as I told you before, these knots are performed at the rectum level and at the duodenum level. In order to make those knots at the duodenum level is relatively easy, because here we see the liver, we see the stomach, and when you have the stomach here, you just have to pull it up, and finally you find this whitish structure. This whitish structure is the pancreas, and here you have the duodenum, and you will see a ligament here. This is the duodenum colic ligament. So usually what we do is to cut it, and we will make the knots here. So we have some strings, as I showed you before, and what we will do is to separate the loops by making a couple of knots separated in general terms by 2 centimeters because we will cut in between. I insist, this is something that we prefer to do, especially if we are doing a complete necropsy and we do not want to contaminate anything. The second knot is in the rectum, so if it must be in the rectum, we should go to the most caudal part. Here we have the urinary bladder, and here we have the rectum. So the rectum usually is plenty of feces, so being plenty of feces, what we prefer to do is just to remove the feces to one side, especially to the upper side, and then the ligament that we can see here, we are also even with the finger to cut it, and we will make the 2 knots exactly here. So we will take again the strings, as you can see here, and we will do the 2 knots. With this procedure, what we avoid is basically presence of feces when we are removing all the intestinal loops. This is one here, and the second one, which is being performed caudal. We try to do it 2-3 centimeters apart, at least, like that. It's a double knot in order to be sure that will work. And now we are in the possibility of separating the whole intestine. How we can do that? The easiest way is, of course, to cut first by the colorectal ligaments that we have been performed. So this is relatively easy. And then, as you can see, there are all the loops there, but it's very easy to identify the different structures, and especially the ligaments that you have here that should be cut. And this is relatively easy. We have to take a little bit of care for not cutting other organs while doing so. The only organ that we will cut it in purpose, really, it will be the pancreas. Here you have the head of the pancreas, which is rather evident here, but we will keep doing so. So we are just approaching, in fact, the duodenum, and when reaching that point, we will have to cut the pancreas. So if we are able to do it properly, it will reach a point in which, look, the whole intestinal mass is just touching the duodenum. So we will be able to cut for the duodenum, and then the whole intestinal mass is ready for the throughout the study. So we will leave it at that way. Then we will remove the stomach together with the liver. In fact, we like to do it together because we want to be sure also that the choledoch, the bile, it flows correctly from the liver, from the gallbladder to the stomach. So we will do such a cut, trying to remove both stomach and liver. For the reason we are cutting the diaphragmatic muscle, and as you can see at this point, I got both the stomach and the liver. So we will put it apart and we will study afterwards. Now we will study the stomach and the liver. In fact, as you have seen before, we take them out together, basically because even this is inherited from the small animals, especially in terms of the flow of the bile from the gallbladder to the duodenum. And sometimes, even in pig, this is not such important. In certain specific situations, could be. So what we want to do here is to be sure that this flow is correct. So what we will do now, as you will see, we will remove a little bit of omentum in order to see it much better. But what we will see here is the gallbladder, which looks normal, and theoretically is going to the duodenum, so at that point, so it looks perfect. And what we will do now is just a small cut of 2-3 centimeters of length in order to be sure that we are in the duodenum. And then we will press the bile or the gallbladder in order to be sure that the material is getting out. So I'm trying to do so. As you can see now, the liquid is getting out, right? then it means that it works without problem. Once we have confirmed that the bile is flowing adequately, we can separate the stomach from the liver. So this is relatively easy. Very important, what you see here is the gastrohepatic lymph node. The gastrohepatic lymph node is extremely important for some diseases, especially African swine fever. In African swine fever, even, of course, there's a kind of diathesis hemorrhagic disease, there are certain lymph nodes which are especially affected. And the most affected one by difference, in general terms, is the gastrohepatic one, which looks very red, like a blood bag sometimes, and much increase in size, okay? Then, what about the liver? In fact, in the liver, there's not a lot of pathology that can be ascertained grossly. In most of the cases, we have to go for histopathological analysis. So for the reason to fix informally could be of interest. But there are some issues that could be of interest to be analyzed. First of all, the own gallbladder. In fact, the gallbladder, as you can see, it looks greenish, dark greenish, which is normal. But it's very interesting to know if there's or not edema of the wall of the gallbladder. Probably you have never heard about hepatic edema. The liver cannot undergo with edema. In fact, if there's any edema, must be the connective tissue which is around different parts. And the part in which there's more connective tissue is around the gallbladder. So from this point of view, what we will do is a longitudinal cut of the gallbladder in order to see if there's or not edema. The way of doing so is just with a knife, trying to cut, of course, all the bile is gone, and then to try to analyze if in the wall, which is perfectly seen here, there is or not edema. Edema of the gallbladder is rather typical on situation with selenium and vitamin E deficiency, specifically in the form of hepatosis dietetica. And it's rather typical. Sometimes even you see a pinpoint puntiform forms which are at the very end central lobular necrosis of the hepatic lobules, and this sometimes can be seen. So when you have in combination this observation together with the edema of the gallbladder wall, then you are quite close to the possibility of being hepatosis dietetica. However, you must remember that, for example, in African swine fever is quite typical as well, hemorrhages in the gallbladder and also edema, a severe edema of the gallbladder wall. Okay, and in terms of liver, there's not much to be seen grossly. What we usually do is several cuts in the different lobes, and those cuts are basically in order to be sure that the parenchyma looks normal. Sometimes we are just pushing a little bit, try to see the consistency. If we have to take a sample for histopathology mainly, then you will see that the sample could be following the same examples that we have seen before, small pieces, general terms, relatively easy to be fixed, as we see here. Now we will study the gastroenteric tract. For the gastroenteric tract, we will start with the stomach. The stomach is a relatively easy part of the intestine to, the gastrointestinal tract to be analyzed, and you will see that we have a major curvature and a minor curvature. Here is the duodenum. Remember that we have been performing a knot here. We have had a cut just to analyze if the bile flow was correct. So the right way of opening is always from the duodenum following the major curvature until the diverticulum. Remember that the stomach of the pig has a diverticulum here, so we will cut at the diverticulum level. Of content, we will see if there's some liquid. The liquid even is of yellowish, greenish color, until here the diverticulum, as I indicated before. So here we have the diverticulum, and then what we will do is just to open, and the interesting part is to see the different areas of the stomach. As you can see, there's certainly a minimum amount of liquid. Here we have the pyloric part, we have the torus pyloricus, which is here. So the pyloric part will be here. This is the fundic part. And very importantly in pigs, although here is of yellowish color because of the reason I indicated, there's a kind of rectangle or let's say a square, which is just the entrance of the esophagus. So this is the pars esophagia. And why is so important? In fact, 95% of the pathology in the stomach is gastric ulceration, and gastric ulceration of the pars esophagia. So the part that you should look is basically here, and is where you can see erosions in the very first moment sometimes, or previous to the ulcer, and then ulcerations. And sometimes in chronic ulceration, you see almost crateriform structure here in the pars esophagia. Remember that you can see also hyperkeratosis. Hyperkeratosis, in general terms, is the very first step for the evolution towards a gastric ulceration. Not always, of course, but it's one of the possibilities. So what we have to analyze basically here, besides the pars esophagia, is also the integrity of the mucosa, the lack of potential hemorrhages, the potential erosions or ulcers, especially in the fundic part. Remember that if we have been treating the animals with non-steroid anti-inflammatory drugs, PEROS, the possibility of having different erosions and even ulcerations in the fundic part is not unusual. In fact, it's quite often seen. So from this point of view, there's not much to analyze here in the stomach. Of course, the lack of content is always suggestive that this animal has not been eating lately. Of course, if it has been fasted, this has been in purpose, but if this happens within your farm, this means that for whatever reason, this animal have not been eaten, might have fever, could be sick, etc., etc. So this is something important to take into account. Like, for example, if you are talking about a lactating pig must have milk, clotted milk inside the stomach. If this is not the case, something wrong is going on. When talking about pig diseases and pig pathology, it's considered that respiratory problems and digestive problems corresponds to close to 80% of most of the issues. So from this point of view, digestive tract analysis and study is very, very important. And the point is that we have different diseases affecting in different areas of the intestines. Some of them are just affecting the small intestine, others just the large intestine, and others may affect both a small and large intestine. So from this point of view, it's very, very imperative to know which are the different areas of the intestine, because when we have together, especially within the carcass, sometimes it's difficult to know if this is jejunum or duodenum or ileum. So it's really, really important to assess which part we need for each case, because not all diseases need the same type of sample in order to analyze potential pathogens. In this form, of course, it's all the package together. However, we can rapidly assign different situations. Of course, here we have the rectum, so we can perfectly elucidate this part. And here we have the duodenum, because are the part that we have noted, if you remember. Something which is very clear, the large intestine, because it's of darker color in general terms. Remember, diseases like swine dysentery, diseases like porcine colonic sparacytosis reflects only a lesion in the large intestine, not in the small intestine. There are others like salmonellosis, which can affect both in the large and a small intestine. And then there are other diseases, especially in the fatteners, which like the porcine proliferative enteropathy, which can affect especially a small intestine in its last part, especially the ileum, but not only the ileum, also the cecum and the cranial part of the colon. Remember that the porcine enteropathy, proliferative enteropathy, they have different forms. One could be the porcine intestinal adenomatosis, but there are other forms, which is the hemorrhagic form, and then there are very scarcely seen forms, which are the necrotic enteritis and the regional ileitis. But then it's very important to locate specifically the presence of the ileum. So the most easy way to look for the ileum is by detecting the cecum. As long as we are detecting the CECUM, then, and we can go for this side, we will find the ileum. So, as you can see here, we have the CECUM, and here we have the ileum. So, to detect the presence of the ileum should be easy. And if we are taking samples from here, we are pretty sure that we are trying to, in this case, for example, confirm or discard the presence of porcine intestinal adenomatosis. However, as long as attached to the CECUM, we will never lose this reference. However, of course, if we have the whole package and I'm looking at that way, it can be difficult sometimes. So try to look for your reference, and the reference is always the CECUM. Then it could be interesting as well to take samples from other different parts of the small intestine, because of course we can think on clostridiosis. Most of the Clostridium perfringens mainly are affecting the small intestine. Remember that Clostridium difficile can affect the large intestine, especially the colon. E. coli, of course, different forms of post-weaning diarrhea. So the type of samples that we need, that could be in most cases bacteriology, in some other cases PCR, etc. And of course, histopathology can help as well. So we will decide which is the best one for each disease. So one of the things that we like to do, especially when we are with the students, because it's the only way by which everything is well located, is to see where's the duodenum, where's the jejunum, and where's the ileum. The ileum has been very easily identified. And for doing so, something that helps a lot is by removing the mesenteric lymph node. So what we will do here now is to remove the mesenteric lymph node first, and for that reason, I locate again the CECUM, the ileum, and as long as I'm taking the ileum, so you can see it very well right now here, I see the mesenteric lymph node. The mesenteric lymph node is really, really big. It's the biggest lymph node into the animal. So what we will do now is try to remove as much as possible such lymph node. So what I will do here is to expose the lymph node maximally, and you will see how big it is. Look, it's all that part in there. So we will try to remove as much as possible. This, of course, may take some time, but it's not a lot of time, really. So, as you can see here, we will try to be fast. Even sometimes when you are faster, you are just cutting one of the loops. We will try not to do so. Look at here. It takes some time, that's true. Remember that in certain conditions could be much more difficult, but on a table it's always much easier. And look that we have removed a big part of the mesenteric lymph node. Sometimes, and following up some other comments that we did on taking some lymphoid tissues, especially for the systemic disease caused by circovirus, to take one piece, small piece of lymph node could be more than enough as well. So by doing this, it's amazing, but we have separating in a great manner the intestine. So now it's relatively easy to know where are we, because remember that here we have the ileum. So we will isolate a little bit more the ileum. Here we have the ileum. And then it would be relatively easy to put the ileum into the surface of the table or the surface on the floor that you may have. The ileum in pigs is the part where we find the pair patches. So if you are interested in pair patches, it's again lymphoid tissue, again important for disease like the systemic infection by PCV2, and of course very important as well because it's the place in which porcine intestinal adenomatosis is usually seen. So the pair patch sometimes can be seen grossly through the serosa. Sometimes it's complicated, and in this animal it's not that clear, but when we are opening, we see that there's one part which is thicker in the wall. Then we can perfectly assess that that particular part is the pair patch. We can take the different types of samples. Of course, we might be interested in bacterial isolation, not for Lawsonia intracellularis, because at the very end, for Lawsonia intracellularis, we are detecting it especially by PCR. PCR sometimes in feces, but it could be, of course, PCR on ileal content. But it can be also detected by immunohistochemistry. So it could be interesting to take a sample for, in this case, histopathology and further immunohistochemistry. Then we will take a sample to fix in formalin. For other pathogens, especially Clostridium, E. coli, or even Salmonella, we may prefer isolation, even prior to do PCRs, because sometimes we want to characterize as well the agent by means of PCR. So we will try with a sample for such isolation. Of course, when we have large intestine lesions compatible with swine dysentery, porcine intestinal spiroctosis, etc., PCR is the most typical technique to be used to detect those pathogens, but in a number of cases, especially when swine dysentery, it's quite interesting to do isolation. As you have seen, I have separated the different loops of the small intestine, but not the ones of the large intestine, so we keep them together. So what we will do in terms of bacterial isolation, imagine for a while that we are expecting the possibility of colibacillosis, post-weaning diarrhea associated, and we are interested in isolation. So the recommendation is to take a relatively generous sample, 20-30 centimeters in length without any problem, to knot on the edges and submit such a sample. How can we do that? The easiest way is take the part of the intestine that we want to submit. In our case, we prefer jejunum towards the ileum. Sometimes we can take ileum as well. And we are doing a knot on one side, and we are doing the knot in the other side. By doing this sample will not be contaminated, further contaminated, I mean, and it will be excellent for taking it out. Now I will cut on one edge and the other edge here, and this will be the sample that we will use to introduce in our bag and bring to the laboratory. So this sample will be excellent for performing whatever bacterial isolation. But as I told you, it could be interesting to take some samples for histopathological analysis. And we always recommend, in order to cover the whole spectrum, to take samples from the ileum, from the jejunum and duodenum, as well as large intestine. Of course, if our interest is to perform isolation, bacterial isolation of the large intestine, we would proceed exactly like the small intestine. Which type of samples we take for histopathology? For example, if we are in the ileum, we can take one piece. I'm sure I'm within the ileum, no more than 4 or 5 centimeters, and then, and very importantly, open longitudinally. Why do we want to open it? Basically, because what we need is to fix the mucosa, because the mucosa is the part that we have to analyze, the part in which we have to ascertain if there's any lesion or not. And as you can see here, even it's a very small piece, just the middle part, the part that is signaled here with the forceps, all that part is thicker than the edges that you can see here. This thicker part is the one that refers to the pair patch. So this is an excellent sample that we can use for fixing in formalin. This is for the part of the ileum. We can take even more parts from the ileum if needed. We can take a couple of parts of the jejunum. Here we will do exactly the same. So we will open longitudinally, 4 or 5 centimeters in length. Look at here. Here we do not see any part which is thicker than other. So it's much thinner than the ileum, and implies that this is jejunum already. So we can put one piece of jejunum. Of course, since the jejunum is quite long, we can take several pieces. And finally, here we know that this is duodenum, so we can take also a small piece that we will cut as well in a longitudinal manner, and we will put into formalin. Remember that the sensitive part is the mucosa. This is what we need to analyze from an histopathological point of view. Of course, at this stage, we have the large intestine. As I told you, if you want to make any bacterial isolation, we will perform similarly on the small intestine. And if we want to do some histopathology, we will also cut small pieces, 4 or 5 centimeters, to be opened longitudinally, and try to eliminate the feces, which is the most usual situation. However, please don't touch the scissors or the forceps with the mucosa. Try to do in a gentle manner in order to preserve the mucosa. This is very important, okay? Because, of course, if I'm not doing so by just taking out the feces, touching the mucosa, I'm destroying the mucosa. In the cecum, we can take one part of cecum. Here it's easier because being relatively liquid, we can take a part which is really not attached to feces, and we can see the mucosa. Then, when putting within the formalin, we can move within the formalin in order to remove the remnants of intestinal contents. And at that way, we will be able to study the different, first of all, lesions caused by pathogens at the intestinal level, and very important, I insist, be able to identify the different parts of the intestine without any doubt.